front of neck axis can be defined as securing of airway via anterior neck, facilitating emergency alveolar oxygenation. eFONA is the final life-saving measure to reverse hypoxia and prevent brain injury, cardiac arrest, and death. All these guidelines have already been covered, so I won't go into the details. The only situation where your plan A, B, and C fails, if you are managing a critically ill patient in an ICU, or if you are doing an obstetric patient and all the three plans fail, you need to activate your plan D, that is CICO, can't intubate, can't oxygenate. And then you need to proceed for FONA, that is front of neck axis. Vortex presentation very well explained by Balaji sir. You need to stick on the outer green zone, and so that you won't get succumbed down and you don't require FONA. We as an anesthesiologist are well versed not only in operation theatre but in the NORA, managing ICU, managing perioperative physician, and using ultrasonic machine for various needs. Then why not to use scalpel and perform front of neck axis? So, according to the 2004 guidelines, the high pressure oxygenation was delivered via a narrow canal, but then over a period it proved that it gives a fatal outcome. So in 2015 there was a revised guideline which gives us a clear indication to use a wide bore needle or a cuff tube for oxygenation. Hence, all our anesthesiologists must be trained for FONA. Training should be repeated at regular interval for skill retention, and that's the aim of our today's workshop. Little bit about anatomy. We all are well versed, but still will highlight certain things. There is a prominent hyoid bone in the neck which can be palpable. There is a prominent laryngeal prominence which we call it as an Adam's apple, and below that there is a cricoid cartilage. The length of the trachea and all this we know. The second, third, and fourth ring is covered by the thyroid isthmus. Relation of the structures is very important as we are going to access the trachea. Anteriorly it is covered by the skin, superficial fascia and deep fascia, jugular veins and strap muscles. Posteriorly, it's the esophagus and the recurrent laryngeal nerve. Laterally, it is the pair of thyroid lobules, thyroid glands, carotid sheaths, and its important content. Arterial supply is via the inferior thyroid artery, bronchial artery, venous drainage is via the inferior thyroid vein, nerve supply is via the tracheal branch of vagus and recurrent laryngeal nerve. Looking at the Gray's anatomy and revising the pictures of Gray's anatomy, we all know that anterior part of the neck is having many triangles, but the angle of our interest is Jackson's triangle, of which base is been formed by the lower border of thyroid cartilage, apex by the suprasternal notch, laterally by the medial border of sternocleidomastoid. This is the safe area for dissection and giving regional anesthesia. As per the DAS guidelines, the front of neck axis is divided into two types, that is small bore or large bore. The device which can be used to access the trachea. So in case for a small bore, it includes transtracheal cannulation, whereas in the large bore, it includes scalpel bougie technique, cricothyroidectomy, and tracheostomy. This classification is done on the type of conduit which can be used via this diameter. The transtracheal cannulation, cricothyroidectomy, and scalpel bougie technique can be performed at cricothyroid level. Tracheostomy is done at the tracheal cartilage ring. Conduit of oxygen source which is used for transtracheal cannulation is in an oxygen flow module, jet ventilation, self-inflating bag, and the Ventrain devices. So for the transtracheal cannulation, once you identify the surface anatomy or by the ultrasound, which Dr. Saurabh Bhadde will cover in the next talk, once you know cricothyroid membrane, try to use 14 or 16 gauge needle and puncture from the front of neck and ventilate your patient. There are many conventional devices which are available. If not, you can use a intracath which is available of a larger size. This again, repetition of the slide. Everybody has told the importance of this simple gadget, and it should be kept very handy. If you are a freelancer and practicing in an obstetric center and you face a difficulty, the only pressure our gynecologist colleague know is the fundal pressure, and the only distress our gynecologist friend know is the fetal distress. So you won't get any adequate help in that center. So this thing should be kept very handy so that you can at least ventilate. Conduit of oxygen sources are O2 flow modules, jet ventilation, and the newer one which is Ventrain device. Jet ventilation, it is an emergency source of ventilation where the oxygen flow of 15 liter per minute can be used. It has a pressure regulator valve, handheld device, and a high pressure non-collapsible oxygen tubing. We all know the chances of barotrauma are more with jet ventilation. In adult, the jet pressure starts at 20 psi and increases gradually till adequate chest rise and fall is noted. In children, it should start at 5 to 10 psi, 20 bursts of respiration to be given per minute. And here, hand-eye coordination is very, very important. For the Ventrain device, it is a very newer device and a noble device. I guess it will be included sooner in the DAS guidelines. It is meant for single use, but our Indian tendency, we will use 100 times. Then it is positive pressure during inspiration is given via Bernoulli's effect, adjustable inspiratory flow wall. Active suctioning can be done during inspiration. The inspiration is passive over here, expiration is active. With the movement of the thumb on a port, you can do expiration, and equilibrium is created by releasing the thumb as well as the index finger so that the positive and the negative pressure gets neutralized. So this is a video using a cannula in the front of neck axis, connecting it to the O2 flow auxiliary port with 15 liters per minute. A 360 degree you can rotate module. You can use the thumb for expiration and inspiration. Inspiration is a passive procedure, so at least you can ventilate your patient. Now coming to the larger bore front of neck axis, it includes scalpel bougie technique, cricothyroidectomy and tracheostomy. Advantage of cricothyroidectomy over tracheostomy is that it is a simple procedure, can be used in an emergency. It is again a temporary measure, only local anesthesia is required, and there is a less learning curve for this procedure. So once you get the landmark surface anatomy of cricothyroid membrane using only two devices, that is scalpel and the bougie, or the ultrasound to locate cricothyroid membrane, you can have an access through the scalpel bougie technique. The handshake maneuver is the first and the primary step for surface anatomy. You can use your two fingers, the thumb as well as the middle finger, so that you can locate the hyoid bone, and you can palpate cricothyroid membrane with the index finger with the non-dormant hand. Again, a little sophisticated technique of cricothyroidectomy only in the 4 simple steps. This is again advancement of the same which we seen behind. First, here the hook is used so that you can retract the structures and you can get the easy access. A small size tube can be used. Another sophisticated device which includes the Seldinger kit. There is a guide wire. After giving local or transtracheal, you can keep the cannula in situ and you can pass the guide wire through it. Holding the guide wire firmly, you can pass the tracheal dilator and the tracheal tube and secure the access. This I tried on the goat trachea inside the OT. So the needle puncture has been done. Local has been given. Scalpel is used to puncture. Now I am using a bougie. Scalpel kept in situ so as to assist. The bougie is little long, so it goes hanging here and there. You need some assistant help. Then you can railroad the ET tube over it and oxygenate. If small size ET tube is preferable, 5, 6, 6.5, or else if tracheostomy tubes if available with you. Now coming to the conventional tracheostomy procedure, anesthesia given is either local or the fantastic block which are explained by Sujit sir. Supine positions with the neck extended, bolster under the shoulder, head ring to be given and avoid overextension so that you will lose the anatomical landmarks. The trolley to be kept ready, and each and every member from your team should know the equipments what are required for tracheostomy. So the simple step again with all aseptic precautions, you need to give a transtracheal local. Remember, the skin incision is vertical and incision over the cricoid or the tracheal ring is horizontal. Once you exposed it properly, you need not have to cut any of the structure, but rather go on proceeding by finer dissection and separating the strap muscles. Once you reach to the tracheal ring, again aspirate with a needle and confirm tracheal lumen and railroad the tracheostomy tube. What we learn from our surgical colleagues is Bijob's flap. We usually make a flap on the taking inverted U-shaped cut on the tracheal rings, and that flap has been sutured to till the skin. The only disadvantage is that if the suture breaks, there is difficulty for reinsertion of the tube, and the flap will flip back, and there will be again patient may land up in respiratory distress. Now the percute tracheostomy, this is again a more sophisticated device with all the materials inside the set, and it can be done. It is a simple procedure, takes little less time as compared to tracheostomy. ICU or bedside procedure, and the only contraindication is children with the neck mass or coagulopathies or in obese patient where the anatomical landmarks are little difficult. Only thing is this is a little bit costly affair. This we will do at the workstations. Everything is available at our workstations. All the equipments to be kept ready. The things are available in complete set. Then you have to prepare like blue rhino. You have to railroad the tracheostomy tube, deflate the cuff, and apply the jelly. Then you can after giving the position, you can then give transtracheal as a local, take a skin incision vertical, do a finer dissection with the mosquito, then again aspirate and confirm. As this is a bedside procedure, you can see a tracheal cuff over here. So you have to deflate the cuff and remove the tube little back and secure again by inflating the cuff. Once you locate the trachea here, you have to introduce a introducer needle. The movement done for the introducer needle is like a screwing movement, and make a track. Then use this blue rhino dilator with a guide catheter. The guide catheter is very important device in this because it has a proximal marking as well as the distal marking. It will avoid further progression and further trauma to the trachea. So then you can railroad this tracheostomy tube with the assembly which you have already been prepared. Once your tube is secure, inflate the cuff and connect to and start oxygenation. The video was available, but it was of 7 minutes and I could not afford that much time. So in a situation where can't intubate, can't oxygenate and occurs, but it is poorly managed, it will cause a potentially disastrous consequences. If you all ask me what is the incidence of CICO and taking a front of neck access, I would like to tell you that it is only mentioned as 0.003% in operation theatre, but in a trauma unit or emergency unit, it is up to 3%. So everybody in this hall today are residents. Some are intensivists and some are anesthesiologists, some are senior anesthesiologists. But whenever the situation of CICO occurs, we all sail in the same boat. Sailing the ship in the storm is not an easy task, but one can train to sail the ship when the sea is calm. So today the environment is cool and calm, and I urge everyone to take adequate time for hands-on training. So I conclude my talk that a multidisciplinary team approach is required whenever you are facing a crisis. Every team member should be oriented to the new terms, that is CICO, eFONA, the sets, the equipments, and the procedure. As Balaji sir had mentioned, there occurs a cognitive overload and error in airway management and hence delayed in decision making. Please declare yourself at the early stage that you need a FONA because of, as you know, the conduit of vortex, there is a very narrow time to escape, so even you get less time to perform FONA. Initial guidelines, remember about a narrow bore cannula where at least alveolar oxygenation can be done. If you can secure a wide bore cannula, it is the best. You can continue ventilation. And remember 3 R's, repetition of the techniques at regular interval for retention of skill. Please know either one of the guidelines, ASA, DAS or vortex, and kindly master in any one of the skill, that is needle syringus, surgical or scalpel bougie, transtracheal, and you can save your patient. Thank you very much.